I think patients want to feel empowered. And so ChatGPT is another tool, kind of like WebMD, but the next level. And so it's not surprising to me that patients want to use every tool at their disposal to feel empowered about their clinical care. And so I think the question is, how do we ensure that patients are getting accurate information that they can then use, and then also that they're not ingrained biases in these algorithms like ChatGPT, which is a large language model that they're using. And so there's numerous ways we can go with that conversation about patients using generative AI tools like ChatGPT. But in some, I think it can be a good thing, but it does have specific harms that we need to be cognizant of. The second thing I'll say is that it's very easy to think that ChatGPT is thinking when it types sentences to you, right? Because they're longer than a doctor would typically talk or prescribe, and it's not unreasonable. And in fact, there are studies showing that folks believe that chatbots are more empathetic in some cases than doctors, simply because the conversational style is different. And so that's a challenge for physicians, is how do you gain that trust with patients? And how do you ensure that they're not trusting sources that may or may not be accurate, like ChatGPT? And the last thing is that ChatGPT is ultimately math. It's a predictive tool based on tokens and how they've been used before in the corpus of information that it's trained on. And so it's easy to think it might be reasoning with you, but the fact is it's not necessarily thinking and reasoning as most patients would understand it. Things to look out for is ChatGPT can make mistakes. Any generative AI chatbot can make mistakes. They can hallucinate, i.e. making up clinical studies or references that may or may not exist, but in an alternate reality might have existed, right? Because they're predictive tools. So I would just keep in mind that the information you get is really a starting point for you to talk with your doctor or for you to seek out more sources, for example, traditional medical studies. And so from that standpoint, ChatGPT can be really interesting as a kind of a first pass at superficial questions and answers, but you got to go deeper. You got to check the accuracy. And of course, keep in mind that anything you tell public chatbots might be part of their training data the next day. And so there's a privacy concern as well. And so do not write or tell anything to chatbots that you might not necessarily want to divulge against yourself. So just keep that in mind, there's no privacy aspect to it. So there's a number of different ways we can use AI in the hospital. And I'll give you one way is I'm an emergency radiologist. If you come in and hit your head and you come to the Mass General Brigham emergency department, we have AI tools, not necessarily GPT, but other AI tools that can look at your head CT before a radiologist, has a chance to look at it and can tell us, is there a bleed here? Is there something urgent on this head CT, or is it negative? And then they could triage that. They could say, radiologist, read these questionable, possibly acute head CTs first. The probably negative ones you can read later. And so that really helps us treat patients faster, have more patients that are able to leave the ED quicker, and that increases access for other patients. And so that's one way we use it in diagnostic capability. Another way is really preserving the physician-patient relationship. It's not unusual. We all do it. We go to the doctor, and the doctor might be behind a computer, laptop, or screen for the bulk of the visit. And that is not the best way to engender trust in a relationship. And so we're implementing particular tools now that are designed to remove the computer from the waiting room and the patient room. And in fact, you can talk to your physician one-to-one, or your nurse practitioner or your physician assistant. And the tool is in the background, listening to everything that's going on in a conversational way. The tool then transcribes into a patient note that goes directly in the medical record, pulls out billing codes, and does all the administrative work that a physician might be staying up or missing dinner with their kids to do. And so talking to patients face-to-face, reducing tasks after you leave the hospital, these are all good things for patient care, but also reducing worker burnout, which is very important for us. I think that the most interesting research we did was in the early days of ChatGPT. So we're talking 3.5 and 4. We actually took a compendium of bread and butter medical diagnoses, heart failure, abdominal pain, appendicitis, and we ran it through ChatGPT, not to get the correct diagnosis necessarily, but to walk through clinical scenarios as a provider would. That means taking a triage note, minimal information, and asking GPT not what the diagnosis is, but what questions would you like to ask the patient? Getting that information back and then iterating and saying, okay, what lab tests would you like to order? And we benchmark each section of this differential: lab test, then diagnosis, then patient management, against typical answers from these gold standard sources. And actually found that ChatGPT was remarkably good at doing this. And these were early models. Overall, 72% accurate in basically playing doctor. And for us, that was the first study on diagnostic capabilities and clinical reasoning. We published it in 2023 in the early days. And since it's been covered and spawned a lot of numerous follow-on studies about rare disease and imaging and all sorts of clinical conundrums. So what we did was we trained on Mass General Brigham innovation guidelines for innovators, right? Filing patents, what to put in your disclosure, everything you need to know about first financing. And then we created an embedded model that was basically like an inventor or innovator concierge. So the inventor, when they're starting out, can then ask questions to this model. It's a chatbot. And they could give them advice on what to do. Say, I have an idea, who should I talk to? The chatbot would tell you who to talk to based on what specific field or specialty your idea was in, if it's device, digital, biotech, etc. And so we got remarkable results, basically showed it was highly effective in providing the right answers. And innovation, every tech transfer office is limited in its manpower. You can't answer all the emails as a licensing associate or business development associate you get from faculty per day. And so imagine if you had a passive chatbot operating in parallel that can provide concierge service to common questions in context-aware manner for what the innovator was asking. And so that has the ability to massively help early stage innovators learn about innovation, interface with our tech transfer office, ultimately to lead to more disclosures and more business and innovation outcomes. So I think for me, I liken it to an old Steve Jobs quote, which was that some variation of a computer is a bicycle for the mind. I think AI is a bicycle for the healthcare provider, for the physician. And so there will be some physicians who will not adopt AI and they will be walking metaphorically. The ones who do will be on a bike. And in 10 years, we'll be sitting in an electric car metaphorically. And so I think it's really an augmenting tool at the end of the day, right? It can be implemented in several different ways alongside your clinical evaluation of a patient. It could operate in parallel as a second check, because we all as physicians have biases, ingrained preferences that may not line up with how the data suggests, right? We're humans, we don't know all the studies, but AI can say and redirect us, say, you're going to prescribe this dose. Well, based on the patient's past medical history, their demographics, maybe you should change the dose and make it this dose. I will say that I don't think artificial intelligence will replace doctors. I do think doctors who use artificial intelligence will replace doctors who don't. And I think lastly, like at Mass General Brigham, there's always going to be a human in the loop, right? You're not going to come to our ED and only see some sort of AI algorithm and never see a human. Always a human, always a doctor signing off, checking, evaluating every single diagnostic decision at Mass General Brigham. Well, I think I learned that there's a lot of exciting companies like Abridge, who's one of the sponsors of this event, doing incredible things to reduce worker burnout. For example, Abridge has an ambient documentation tool to record patient-doctor visits and transcribe them so that the doctor could spend less time looking at a computer, more time talking directly to the patient. And I've learned that these tools, though, have to be implemented in thoughtful ways. You cannot simply disseminate new AI tools without doing the proper buy-in from physicians, getting the proper feedback from beta testing and changing things that are not working. There was a version, let's say, of an AI tool where you had to open a whole new program outside of our medical record to use it. Turns out that's a big problem, right? You're seeing 30 patients a day. You don't want to change between windows, something that small in the user interface, which led to this tool being implemented directly into Epic. So no changing screens, hugely helpful. So I think those kind of beta tests, feedback from implementation and implementation science really gets the buy-in we need as an organization to implement these widely and have them be used. And lastly, you can't just throw a tool in there and say, okay, see ya. You actually got to monitor the performance, right? AI by its nature learns. Machine learning algorithms change over time. They may not perform the same this week as they performed last week. If you change the patient population and the data going in, they might change their performance metrics going out. So that means implementing an algorithm at Mass General main campus may give you very different results than implementing it at Chelsea Urgent Care or in New Hampshire at one of our sites. And so you have to implement these thoughtfully, knowing what patients and what patient population you're treating, and using those pretest probabilities and putting them in your models for each site.